Okay, I think we're ready to go. So welcome you all officially to the Successful Recovery from Total Knee Replacement Workshop. That's quite a mouthful, but we're here to talk about total knee replacements. And during the workshop, we're going to discuss several different primary topics. We're going to start off with just a basic background information, understanding of what a knee replacement is. Many of you I know have already been through it before or have researched already. So this will probably be kind of a review or recap for a lot of you, but I do just kind of want to get all of those baseline introductory things out of the way too, just so we know what we're dealing with. And then after that, we're going to talk about more along the lines of what you can do leading up to your knee replacement surgery to ensure your chances of a better post-surgical recovery. So things you can do to kind of tip the scales in your favor. And then we'll talk about some of the long-standing issues with total knees as well. I know, Greg, you and Ann already mentioned some things, or mainly you, Greg, but then Ann had some questions that kind of go hand in hand with that, with if you have these issues with persistent swelling, pain, stiffness, what can you do now? Or even it's kind of the same question before surgery too. If you already know you have an issue with that knee in terms of swelling and stiffness before surgery, what can you really do now? So I've touched on that information before, like in my articles and emails and stuff, but this is going to be a much deeper dive. And I really encourage everyone here to ask as many questions as you can, because chances are if you have a question, someone else watching or someone else on the Zoom call here will have it too. So that's the plan. Does everyone have the worksheet, by the way?
Mm-hmm.
They said they were sending it to me. It didn't arrive.
Okay.
I have paper to take notes.
Okay. And Greg, if you don't get all of it, no worries. I'm going to send out after the workshop. I'll send out the notes with everything filled in too.
Wonderful.
Yeah.
Thank you so
much. Please feel free. Yeah. Please feel free to take notes, but then know that I'll also get that out to you as well. Okay. So total knees, gosh, such a big decision for so many of our clients. Are you going to have a total knee replacement? It's really, like I said, it's a big deal. So yeah, I hope all of you have thought through it, and hopefully this will help you make a decision. But just to be, perfectly honest, it's a major surgery. There's some major risks involved. And then for most people, there's some major upsides as well. So when we talk about it nowadays, I really try to encourage people to go into it, first of all, knowing what they're getting into, and second of all, doing everything they can to ensure that, they go into surgery in the best shape possible. So again, that's a big focus of the of the workshop today. Before I dive into the topics though, can I just get kind of some brief introductions from people? Kathy, do you want to start us off and just tell us what your situation is right now and what you're looking at?
Yeah, I'm Kathy Hall. I've had one knee surgery or replacement on my left knee. Now I'm going for the right.
Okay.
And I've never,
okay.
Once I got through the physical therapy, it's been fine.
Okay, good. And then you said you have yours already scheduled, right? For Valentine's Day?
Yeah, Valentine's Day.
They'd be extra nice to you. Yeah.
Mm-hmm.
Donna, do you want to go next? Do you mind sharing?
I'm Donna Bird, and I had a left knee replacement 3 years ago this coming March. And I was wondering some of the same things about some of the, I guess, tightness is not stiffness, and some of the issues that the other California person mentioned. And I have arthritis and potential to do a right one, and I'm trying to avoid that.
Good deal. Do you want to share next, Sandy?
Yeah, Donna, I think you're my neighbor.
Hi, Sandy. Yes.
Literally right around the corner. Hi, Donna.
I'm sorry, I didn't recognize you.
Anyway, I didn't know you had total knee replacement. I had my left total knee replacement 11 months ago, and initially did really well, have full range of motion and, walking, but not walking as much as I would like, not getting up to my 10,000 steps for sure, or even 6,000. And I'm trying to avoid, the right knee is just as bad. It's bone on bone and giving me a lot of problems, but I'm trying to postpone that. I'm not ready for that. And the one that has been surgerized, at night, it just gets so stiff and painful. But if I get up for even a few minutes and walk around, it's pretty good. And we live on a 3-level house, so I was doing stairs right away and back on the golf course after 8 weeks post-surgery on the other one. So I was pleased with all that. But at night, it gets warm, like it's inflamed. Always feels a little warm. So,
Yeah.
and then I've just been doing a lot of PT to hopefully strengthen the right to postpone the surgery on that.
Good. Good. And Greg, do you want to give a little background again? Just you kind of already did, but you want to give us
Yeah.
a quick synopsis
Okay, yeah,
again?
just quick. Yeah, I had knee replacement. It'll be 3 years ago, May 31st. Went through PT. I've had, some issues with it on and off, but I mean, I've remained, active, able to do my workouts, ride my bike, etc. But the further I get away from it, I seem to be having some more issues with tightness, some swelling, not really bad, pain after I, when I am active, and we've done lots of stuff, and I'm told there's nothing wrong with the knee, but I'm struggling with my activity level that I would like to do. I guess I'm not able to do what I would like. I've got it really kind of sore and tight now, and so I'm kind of on a, laying low for a week, trying to get the soreness, and the tightness, and so I can maybe do stuff again, I guess, if that makes sense.
Yeah. Sounds good. Okay, did anyone else want to kind of give us their story before we dive in? Anyone else want to go ahead, Ann?
I have been a candidate for double knee replacement for the last 8 years. I've been a caregiver until my partner passed away in 2021. My goal in 2022 is to get at least one, if not both of them done as a ski racer and a distance runner. That's why I'm in the situation I'm in. I'm talking to all my fellow ski racers. They're back out there skiing. And my goal is I get one chance at this. I can't screw it up. And I want to make sure that I'm doing everything I can. That's why I'm here.
And you also mentioned some swelling in the legs, right? That's kind of one of your concerns.
Well, I've had edema. I had a kidney issue where I had a blocking kidney stone, and I had to get through all of that cleared in addition. And ever since I had the blocking kidney stone, I've had some edema. And everybody says, oh, yes, you've got edema. Well, I don't want to have edema if there's something else I can do. And they're just saying, well, you've got edema.
Yeah.
Very nice. You don't live in my body.
Yeah.
What
Yeah,
else
we'll
can I do? Which is why I'm here.
Yeah, we'll definitely talk about that later on. So this should be good for you.
Thank you.
Great. Did anyone else want to share?
Can you hear me? I don't know if the microphone is on.
Yeah, you're good there, Carol.
Yeah, well, I had my surgery done May 11th of this year, and it's worse than before I had the surgery. It really is. I'm limping badly. I never had that limp. They keep telling me a year, but it seems to me that I should see progress, and I don't see any progress. And I'm really working hard. I mean, I've worked very hard.
Yeah. Okay. And I think I'll have some good stuff for you too today, Carol. So stick with us here. Good. Bev or Barbara, did either of you want to share as well?
Sure. Can you hear me?
Yeah, we can hear you.
Yeah, I had a total knee. Actually, it was a redo. So he had to take parts out and then put the total knee in. So it was a
Yeah.
little more extensive surgery. October 12th. So it's been almost 4 months. And I'm doing great. It's just kind of like the other lady said, I did a lot of recovery in the beginning, but I just have a few questions now. Like, is there still, can I still get more range of motion at this point or not? And just the scar tissue that's around the scar on the top part of the knee. He had to make quite a big incision to do all what he did. So, but yeah, I bike a lot. So that's really good for the knee. So yeah.
Absolutely.
Oh, I wanted to add something I forgot to say.
Sure.
When I went to see my surgeon and I was complaining, he said, well, that's because you need to have the other knee done. And I can't see having the other knee done until this one is working better. But it is one knee's bow-legged now and the other knee is straight. The one that was done is straight. Do you think that could be a contributing factor?
You know, it can, but I wouldn't think that would make you feel the way you're feeling overall. I think
Yeah,
that's a tough sell to tell me to have the other knee done when the first one doesn't feel too great after surgery.
exactly.
Yeah.
That's how I feel. And my physical therapist said, don't do it.
No, I would much prefer you get this, the first one feeling really good before you go on to the second one.
Yeah.
I wouldn't expect the second one to necessarily improve the first one, Yeah. And then Barbara, you're the last one. Did you want to share anything before we dive in? I think Barbara's good, maybe. Okay. Well, good. Well, so let's dive in. Hopefully everyone has the worksheet. And again, if you don't, I'm happy to share that after we get through the workshop. So we're just going to go right through. Again, some of the first stuff is going to be probably more review for most people here, but we'll just get through it. That way you have all that information if you want it. So the first topic on the list is, what is a total knee replacement? What is the surgery? So if you're looking at your sheet there, the surgery itself is a procedure used to replace the weight-bearing surfaces of the knee joint. So those first two blanks there are just weight-bearing. And of course, we consider this invasive surgery when there's a lot of pain in the knee, and especially if the pain is leading to you not being able to do things you want to do, like walk, go up and down stairs, squat down, for the more active people, skiing, biking, racing, all those things that you all mentioned. So that's what we're talking about. We're going to replace those weight-bearing surfaces. When we used to do these workshops in person, I would draw the knee for you, but basically you have your femur bone coming down and your tibia coming up. Those are the two weight-bearing surfaces of your knee. So those surfaces are going to be replaced completely. You basically cut off the ends of each bone and then put those metal components there. And then of course, they're separating those two metal components is that plastic spacer. The other thing that they also do is they shave off the back of your kneecap and put like a little plastic button on there too. So fun stuff. Did anyone actually watch like a video online of the knee surgery itself? Okay.
No.
Yeah. Yeah. So I mean, you can see anything online. You could see a real surgery online if you wanted to, or you can see like the fun little graphic design one where they're just like, oh, here comes like the saw. They cut off real nice the end of this bone and they just put it on, and that looks really nice. But yeah, I never recommend people watch the actual surgical video, by the way. If you're a PT, it's kind of interesting to see, but not if you're the patient. So, so that's the surgery in a nutshell. Of course, that next spot down, we're most commonly seeing that surgery performed in people with advanced osteoarthritis. OA for short, arthritis for short. You've all probably had those knee x-rays where you can see, there should be, let's say, like this much space between those two bones, and now there's this much space, or on one side, it's completely collapsed, and the other side has a little bit of space left. So those are your typical criteria for who's going to be even considering this type of surgery. Most folks are going to get a total knee. That next bullet point down, though, it can be performed as a partial knee replacement for some people. Surgeons are usually opting to go for a partial for people who are like in their 40s and 50s. So they're still relatively young for this type of a full replacement. And then especially if you only have arthritis in one compartment versus the other. So like the inside knee compartment versus the outside, they might consider a partial just to kind of delay the need for a full replacement. Nobody here had a partial, correct?
I had a partial first, and it
Oh, there you
didn't
go.
work.
Didn't work?
The bottom piece did not adhere to the bone. So it was slipping when I walked.
Ugh.
That was not a factor of the surgeon. I think it was just my bone didn't accept it. So this time he had to take all that stuff out and then put a screw down the bone in the front to keep that piece intact.
Gotcha. Oh, that sounds fun.
That was yeah.
Yeah. Yep. And then last kind of bullet point on the first topic is that surgery, of course, this is kind of a no-brainer, hopefully. but it should only be considered when conservative options have all been tried. Which I'm guessing that probably doesn't need to be said, but this is basic information. Hopefully you've tried PT. Most folks have tried any number of injections by then, and surgery is now the best option. So before we started recording the video, we talked a little bit about how do you know if you're ready for total knee surgery. So that's the next kind of topic. Before I go into that one, did anyone have questions on that first kind of list of topics? Cool, pretty straightforward. So how do you know if you need total knee surgery? The first thing you're going to consider is that you probably have severe knee pain that's going to limit your everyday activities, as opposed to knee pain that just kind of comes and goes. So, a lot of our clients in the clinic have arthritic knees. They have other issues with knees, IT band issues, patellofemoral issues, but typically for them, their pain will come and go. When it comes to someone considering a total knee replacement, it's usually pain throughout the day and sometimes throughout the night. So for everyone on the video, when you're considering total knee replacement, are there specific activities that have really stuck out as like, well, I can't do that. Now it's time to consider surgery?
Yeah.
Shout
Walking,
out an activity. Walking?
walking got, so I really couldn't walk very fast and I was limping a lot.
Yeah.
Same with me.
Walking, and I couldn't ride bike, exercise bike, anything like that prior to my surgery. It was just too painful.
Yeah. Stairs again, stairs, squats, stuff like that. Yep. And again, I kind of just mentioned this, but moderate to severe pain while resting. That's one of the fill-ins there, resting day and night. Again, if you just have the other types of knee pain, which could include some arthritic pain as well, typically if you rest, it's going to feel good. You go to sleep and it feels good. People that are getting closer to making that decision on a total knee replacement typically are having pain pretty much all the time, whether they're resting. Yes, it hurts more if you walk or exercise or ride a bike, but it's pretty much there all the time. And that was kind of the next bullet point too, long-lasting knee inflammation and swelling that doesn't improve with rest or medication. Not that any of us want to live on ibuprofen or Aleve, but at least it can kind of prolong the process if you're taking it occasionally. And then I think Carol mentioned this, but the next one, D, is a bowing in or out of your leg.
Yeah, me too. I have that.
Got the cowboy leg, right?
Yeah.
Yeah, looks like you riding a horse. Yeah. And that typically happens, by the way, when the inside compartment of your knee, not the outside, but the inside compartment of your knee is more arthritic than the outside. So that inside compartment is just squishing down and then your leg is bowing out. And then lastly, how do you know when you're ready for total knee surgery? Significant stiffness in the knee. So some people go into total knee surgery with full motion in their knee, but a lot of people don't. A lot of people already have stiffness, pain, swelling, some of the things that you guys already mentioned. And then I was kind of talking to Donna before we started the recording, is for a lot of people, deciding if they need the surgery is a very personal decision. You'll hear really general advice from, say, a surgeon who just says, put up with it as long as you can. But that advice, if taken too far, actually can be detrimental, because if you wait until the point where you really can't do anything and you're no longer walking or biking or able to go up and down your stairs, and then you decide for surgery, unfortunately, if you wait that long, then you can be in really bad shape going into surgery. So then you're digging yourself out of a hole coming out in terms of getting your strength back and your endurance back throughout your body. So I always tell folks, just try to determine what that sweet spot is for you. And if you're an avid skier and you say, I don't want to miss a single season of skiing, then you might take that into consideration and schedule that surgery a little bit earlier than you might have if you were just saying, I'm just going to hold out for as long as I can.
There's also the issue of, as you get a lot older, the anesthesia is really hard on your brain. That's a thing to consider. Not that I want to rush into it.
Yeah. But it really is that fine line of getting into surgery when you're in pretty good shape, but you can see the writing on the wall versus absolutely just waiting and waiting and waiting and waiting and then trying to schedule it. The other thing that you run into now as well, especially since COVID, is that you might decide that you're ready for surgery, but the surgeon may not be able to get you in for months at a time.
Right.
So that's a real consideration too. Kathy, how long ago did you have to schedule your surgery?
Oh, I was due to have it done in February
Yeah,
or September, I'm sorry, and then got canceled. And
Yeah.
now it's the 14th of February.
yeah. So that's 5 months later, right? Yeah.
Yeah.
Or did I do that right?
And I
Yeah.
had gone to him before that too. So,
Yeah. So another factor to consider is delayed scheduling and potential postponements even after you're scheduled,
right.
depending on hospital capacities and stuff. Hopefully most of that stuff's behind us now, knock on wood. But you never know. So. Okay. Any other questions before we keep cruising along? All right, all right.
Look, I'm
Chris?
gonna throw one at you. How
Sure.
important is it to have a care person with you? Because that's been the reason I've been within 12 hours of surgery twice. And the initially time they said I could go to Touchmark for a week. Now they're saying I have to have a care person and I will have no family member on the east side of the Cascades after June. So I'm trying to get in before that. How important is that?
Are they saying now, Anne, that you can't go to Touchmark, that you have to go straight home?
Well, I don't have that range of dates to see if Touchmark has room in their rehab center.
Oh.
But I mean, they're
gotcha.
saying you have to have a care coordinator. The care coordinator has to go to all your appointments with you. My care coordinator is graduating, getting married and moving to Tennessee in June.
Oh, wow. Yeah, so it sounds like, correct me if I'm wrong, but it sounds like they're
How
saying,
important is that?
well, it sounds like they're saying they can't guarantee you to go
Yeah.
anywhere.
Which
Yeah,
I
so
didn't
if
know
that's
about.
the case, then it's pretty important to have that person because you're gonna need someone.
Do they have, anybody know they have care coordinators for rent? I'm not kidding either. Because
might.
my girlfriends, one of them is in Colbert and doesn't drive, the other one is in Sandpoint, and the other one is here working. I'm not one of these people that has 50,000 followers on Facebook.
It's not too late, yeah.
I thought
No.
there were people that could at least come in for part of the day, but you'd need to be set up so you could access your bathroom and things on your own and you'd need a ride maybe the first, well, you can't drive for a while.
Yeah,
Well, I'm doing my left
But-
first, and I've got automatic. I have driven myself home from a ski crash on Mount Hood this summer with the left side totally immobile and driving with the right foot. I can get
Yeah.
myself around. And I have looked at changing my house around and I'm getting a smaller bed because my bed's too high according to measurements and all these things. But I'm just wondering how important, if I can get myself from point A to point B, because I do have a PT place within about 6 blocks. So, and I don't have to go out in the arterials. I could stay on the back roads to get there.
yeah.
How important is this person? Just a comment.
Very important.
Pretty important. Yeah, pretty important.
Okay.
And again, if you could find, you might be able to call like the local caregiving companies and see if they do anything like that, or you probably have to pay out of pocket, although maybe your insurance would cover some of that. But yeah, I would definitely get somebody who's there to help you.
The first couple of weeks.
Mhm.
Yeah. Yeah, first 2 weeks can definitely be rough. And you want someone, and basically you want someone like helping you cook your meals and stuff too, and bringing you your ice bags and
The ice, yes.
The ice.
yeah.
Yeah, probably the ice bags. You could DoorDash the food.
There you go. That's true. Yeah.
That
You could-
DoorDash pretty quick.
Yeah. Yeah, I would definitely do some research on that, Ann, and see if you can find someone, because yeah, better safe on that
Thank
than
you,
sorry.
everybody who's had this to tell me, because I haven't been there yet. And the reason I couldn't do it when I was a caregiver is because I had to take care of somebody and feed them and make sure they made it to the bathroom. And
Yeah.
with Mitch, that didn't work with two of us in the house because nobody could pick him up. Okay,
Yeah.
thank you.
Yeah, you're
Well, what-
welcome.
One thing that happened to me, I'm pretty tough, but I could not take any of the pain medication. So with a massive knee surgery, that's kind of rough. So it just kept making me throw up. So I had to have the ice, on that knee almost all the time. And like they said, I really needed somebody to do the ice thing. I mean, it sounds really simple, but getting up and down, all the time when you can't have any pain medication is tricky. And I've never been allergic to anything in my life. So I guess you just never know what. So without pain medication, I definitely needed somebody around. So you just don't know. I mean, like 2 weeks, I think then you can start maneuvering better.
Mhm.
Okay.
It's a really
Yeah.
good point too, with those pain meds. I would
And
say probably 1 in 10, 1 in 20 people who have no previous problem with pain meds will be severely nauseous.
Yeah.
And for
Yeah.
those 2 or 3 days, that person can barely do anything.
Yeah.
Exactly.
They
Yeah.
come to the clinic and they look green and you're
Yep.
just like, oh, like we can't do anything until you get off those meds. And
Yep.
yeah,
It was
good
bad.
point.
Yep.
okay.
So you just don't
Does-
know why
does-
it's have a person available because you don't know. Maybe they'll be fine, but maybe you won't. So
Thank you.
Does intravenous, I know there's this one doctor in town that does intravenous pain medication direct to the incision. Do you think that would be less harmful? I mean, less nauseating since it's not going through your stomach?
I don't know.
I'm not sure, but usually afterwards they're going to have you on oral pain meds.
No, but there is one I know because I've met the woman and talked with her. It's
Oh,
they hook you up and they have like a little drip line straight down to the site and they help monitor you. They call you and monitor you and
oh,
because I thought that'd be kind of a neat deal because then you
That
don't
would
have
be
the
nice.
side effects maybe of,
yeah.
anyway.
Is
I
that through the surgeon's office?
I actually had that when I had my elbow surgery a number of years ago. For about a week, and then you go in and they just pull the little drip line out. But when I did my knee, that wasn't even an option for me, at least. So I don't know if they would even do that with a knee replacement. I'm not sure.
Well, there is a doctor in Spokane
Okay.
who does it.
Who's that, Donna?
I would have to check further
Okay.
because I've forgotten now because I wasn't going to that person.
Okay.
But and this has probably been 3 years ago. And I
Okay.
think they were experimenting with it maybe or trying it.
If you figure anything out, would you mind letting me know? Just
I will if I can.
give me a call or email me. Yeah.
I thought that sounded good because then you wouldn't have your side effects. I mean,
Yeah, that would be nice. Yeah. Absolutely. Okay. All right, cool. Let's talk quickly then on number 3 about just basic risks and complications with surgery, and then we'll just keep plugging along. Infection, of course, kind of a nasty one. That occurs in less than 1% of patients, though. I don't see that very often. I've seen a few in my 15 years or so, but it's not super common.
Mm.
Deep vein thrombosis is more common for sure. That's about up to 15% of people after total knee. So that's characterized by like swelling and pain, tenderness behind the calf. So just good things to be aware of. And basically with this list I'm going to give you, just be aware of it. That way, if you have complications, you can reach out to your therapist or your doctor or the nurse. I find the nurses are really quick and easy to work with for the most part. Nerve injuries, not too common either, luckily. Once in a while I see a nerve injury, usually in the lower leg. The next one, unfortunately, more common, persistent stiffness, pain. That's somewhere between 8 and 23% of people will have that. That's kind of a big range. That just depends on which study you're looking at. I feel like it's about 1 in 10 personally.
Okay.
And we'll talk about that in a little bit here. That's kind of a main topic for today. And then the last one, the prosthesis will fail in approximately 2% of people at 5 years out.
Oh, really?
Yeah, not real common, but it does happen.
Hmm.
So most of those things are just things to keep aware of. I always encourage people after total knees, if you ever think that something isn't right, you feel like the pain is more than it should be, you feel like the swelling is out of control, oh, you feel like your incision isn't quite right or it's bleeding too much, I always just say, call the nurse, ask the nurse. They'll usually get you in, take a look at you, and at the very least, they can tell you nothing's wrong.
Well, and the good thing is when you're going to your physical therapist, you folks have seen so much of this, you can advise people like this isn't how it should be,
Yeah,
because sometimes people I think are hesitant to do that maybe, or.
yeah, absolutely. Absolutely. Talk to your therapist. But if say you're on a Wednesday and your appointment isn't until Thursday, just call in, they don't mind. Hopefully they don't mind. It's their job. They like helping people. Okay, so let's talk then about that, what we call stiff knee syndrome, because that's a big one. And talking with a few of you so far, there's that persistent, pain and stiffness and swelling, and it could be mild or it could be pretty significant. So let's get into that topic. What does it look like, first of all, for the average person with stiff knee? It's just the knee always feels stiff. For most of them, they not only can they not fully bend it, but they usually can't fully straighten either. And it really throws off the way they walk. So when you're walking with a stiff leg, that again won't bend freely when you're trying to walk, and it won't straighten when you're trying to extend your leg out in front of you to walk, it can really throw off your walking pattern. And it can go with, again, swelling and hotness and things like that around the knee too. So for most folks, it's going to result in an ability permanently to bend and straighten the knee.
Mm-hmm.
So that blank there is just the word bend. The biggest risk factor for anyone, and this has been researched pretty well, in developing some severe stiffness in their knee, is just immobility. And that's immobility after surgery. So basically, when in doubt after surgery, get up and move around. There's a fine line there too, of course. If you're up on your knee too much after surgery, you can make it worse. You can make it more swollen, you can make it more painful. But definitely get up every half hour to an hour and move around. If you're just sitting, in the recliner on the couch, that's your number one biggest risk factor for developing a stiff knee. It's just because you're not moving it enough.
Is that, Luke, does that hold true for at night too? Is that the primary reason it gets so stiff and sore at night? It's because it's just not moving?
Yeah, good question. So, at night, I think you should definitely focus on sleep. Just any sleep you can get is so important for your body to heal. But yeah, that is why you're so stiff in the morning. Absolutely. Because all the swelling just settles in. I usually advise people with sleeping at night, if you can elevate your leg, that's a great thing to do. Keep that swelling from really pooling in there. And, swelling varies pretty widely among people. Some people have, very little swelling in the knee after surgery, and most people have moderate levels of swelling, and some have severe swelling. So that's a big one at night too, Sandy, is just how much swelling you have.
Is it important to move around long-term also, not just like I'm 9 months out, I should still be moving it a lot?
Absolutely. Yeah.
Forever?
Good question.
Oh.
For most people, it's not forever. For most people, it's like 6 months, sometimes up to a year, they say. But usually I feel like it's 6 months, you've got a pretty good understanding of what knee you've got. And somebody asked us earlier, which we'll get into, I think that was Ann, can you still gain range of motion later on? And the answer is yes. Overall, you can gain range of motion 6 months out. It just gets really hard to. So, you have like this window of opportunity for gaining your range of motion, and earlier is best. So get as much range of motion early on as you can. But then, week 6, week 8, week 10, you're still gaining motion. You just have to really fight for every single degree at that point. Whereas early on, you have a good opportunity to get a lot of motion before your knee has any opportunity to really stiffen up. Which I think I'm jumping ahead a little bit. Yeah, I'll save that thought for later if you guys don't mind. I'm going to talk to you about how to really, that's number 6 on your worksheet. So we're getting there. But the top 3 things you can do to prevent your knee from getting stiff knee syndrome: keep moving, like we just talked about. Just keep moving and moving and moving. Doesn't have to be a ton of movement, but you've got to get up and frequently move throughout the day. So that's the biggest one. Using compression stockings can really help with this too, because we've talked a little bit about swelling. So a lot of our clients come in after total knee surgery and don't have any type of compression garment at all. And I don't know if that's just the surgeons aren't necessarily recommending it or the follow-up care isn't recommending it, but it's always a good idea to have a compression stocking after surgery. And then the other big one is prehab before surgery. And we're going to talk about prehab in just a minute here. Did anyone do prehab before surgery, where you go in either by yourself or with a PT?
I
No,
did.
I have a list of prehab exercises I'm working on, and I'm also prehabbing by trying to ski to get my ski muscles going.
There you go. It's good prehab. It's great. Yeah. So the next bullet point then is prehab. So prehab is actually something they've researched, and what they found in that research, which is on your top bullet point there, is that it can improve your chances of a quicker recovery by 29%. So that basically means you'll get your motion back faster, your strength, your mobility back faster. And the people in the study had a much lower likelihood of going to a nursing facility. And that study was done in 2014. And at that time, everything was very straightforward with total knee surgery. Back then, you were in the hospital for 2 to 3 days. And then it was a matter of, are you going to like a rehab facility if you're really having a hard time, or like a skilled nursing facility if you just need some extra help, or are you going home? A lot has changed though since then. They're doing day surgeries now with total knees. If they can avoid admitting you to the hospital, you're not even going into the hospital for a day, let alone 3 days was standard back then. And nowadays, I think they are trying to keep you out of the nursing home too. So I think if anything, I think prehab has become even more important, because they're basically trying to keep you away from all this intensive care. So when you look at going home as quickly as possible, I think it's in everyone's best interest to do some level of prehab, whether you do it on your own or with a PT clinic or however you do it, but just to get in really good shape before surgery. So on that note, let me give you kind of the blank spots to fill in on our worksheet. The first one is your knee range of motion. You can spell that out if you want, range of motion, or just put ROM. So that's one of the big things for prehab. So we're going to assess your range of motion, and then we're going to basically get you on a program to start, improving your range of motion as much as possible. If you go into knee surgery and you can only bend your knee 90 degrees versus if you go into surgery and you can bend it 120, you could imagine your recovery process is going to be quite a bit easier if you already have full motion. The other focus, of course, is that we're going to focus on your muscle strength. So muscle strength is typically assessed in prehab and then improved as much as possible. And there's a big emphasis on your quad muscles with this type of surgery. So the big muscle group right in the front of your thighs, your quads, big emphasis on that before surgery, on activating the muscle, making sure you have a really strong quad contraction. And then if you can improve the strength, functional strength like squatting, steps, or just basic strengthening like the ability to extend your knee with an ankle weight, something like that. Any improvements you can make in your quad are really going to help you after surgery. And the big reason there is that your quad is just basically, it's just beaten horribly during surgery. It takes a real beating, and there's a lot of pain and there's a lot of swelling. And so anything you can do to get that quad activated easier after surgery is really helpful. And then lastly, on prehab, you should have a complete set of home instructions for what you should be doing after surgery as well as before. So it gives you an opportunity to just kind of get in that mental space. I do feel like the surgeons do a really good job nowadays, though, of giving you exercises before and after surgery. So that's pretty nice. Lately, within the last few months, the surgeons are now starting to refer more for PT before surgery, just to go over the exercises and also to go over how do you set up your walker, how do you set up your cane, how do you get in and out of your car. So they are starting to refer to us even earlier now, just because they're anticipating people going straight home. Okay, that's prehab. Anybody that have questions about the prehab phase before we go into post-surgical? It sounds like everyone here is already doing exercises if they're planning on having surgery. Is that pretty accurate? Cool. No one's just completely sitting around, just waiting around.
I wasn't given any exercises before. I was not.
Oh, okay. And Carol, you're in New York, correct?
Yes.
Okay. Yeah, I don't know if that's a regional thing or.
No, my physical therapist said that he should have given me exercise. He should have sent me to physical therapy before, especially since we had that pandemic and we were all pretty, we weren't very active.
Yeah. Yeah, and everyone was waiting. Yeah. Okay. Well, let's switch gears then to post-op. So we're going to kind of go into like post-surgical and then even beyond post-surgical. And that's where we're going to get into a lot of questions people had early on. Sorry to make you wait this long, but I think it just made more sense in my head to just, go linearly as opposed to hopping around. So after surgery, the first one there is walk. We kind of already talked about this. Walk as much as you can, focusing on equal stride lengths. The easiest way to consider walking after surgery is you just want to try to walk without thinking about it too much. So, if you need to use a walker, use a walker. The real important part is that you're walking normally. You don't want to feel like you're limping around or, taking a short step and a long step, anything like that. So I highly encourage people just to use the walker or the cane, whatever you need to use so that you can walk normally. And then as walking becomes easier and easier, then you can reduce your reliance or reduce how much weight you're bearing through the walker or the cane. Don't get too worried though about the device itself though. It's not something you're going to use for a long period. You basically just don't want to screw up your walking pattern. Because if you walk with a limp for long enough, that becomes your new normal. It's hard to get that out of your brain. The new normal, something I should never say.
Not nowadays.
Yeah, it's like a loaded term. Okay. Most folks are going to be independent with walking within about 2 weeks. But again, if it takes you 3 or 4 weeks, it's not really a big deal. Just walk normally. Number 2, which we're going to talk about quite a bit, is keeping your pain and swelling under control. Bev, you mentioned narcotics. The hardest part when you have an adverse reaction to narcotic pain medication is that you're going to have a harder time with pain. And really, pain and swelling are your biggest barriers to your immediate rehab phase.
Yep.
So if you're in a lot of pain, it's not that easy to stretch your knee.
No.
We all have our limits, even if we are pretty, tough and wiry. But, pain is pain. And swelling is, to me, one of the biggest. If you could take away one thing from the workshop for most people, I would say swelling is underappreciated. So swelling can be the number one reason why you're not getting your motion back, because swelling hurts.
Mm-hmm.
And when your knee is super swollen and your PT and everyone's telling you got to bend that knee, you're at 85 or you're at 90, we got to get you to 120 or 125 or 130. And the knee is just literally feels like it's going to pop because it's so swollen. You can only do so much with that.
Mm-hmm. My surgeon didn't recommend one of those knee, what do you call them? The knee ice machines that the athletes use. He
Like
didn't.
an Iceman.
Yeah, but I ended up buying one, maybe not as fancy as some of them, but I did get an ice machine. And I'll tell you, I think that made the huge difference.
Wow.
I put that thing on and elevated the leg for hours, and it just constant ice. And I think my swelling went down quick.
Yeah.
Constant, swell, or like you said, elevation, ice, compression. what we've gotten to in the last couple of years at the clinic is we have entire leg compression devices, which I think is probably even more preferable, but definitely the Iceman is great for that localized knee compression. We got into this because we started doing lymphedema. We had a couple of therapists start doing lymphedema, which is going to make sense for you, Anne, in just a minute here. But basically, you take a whole leg and you elevate it, and then depending on the device we have, there's either 4 chambers or there's 8 chambers. And so the whole thing fills up with a certain amount of pressure. And then starting from your foot, moving up towards your thigh and your groin, it's compressing, and then it releases, and then it compresses. And then it releases. Yeah, so it's actually pumping that swelling back towards your groin and your abdomen, where it can be recollected by your lymphatic system and your venous system.
Yeah, that's very good.
Yeah, so we use that with ice. And yeah, I think early on in your rehab, again, you need to really be focused on getting that swelling down. And a lot of PTs, myself included, probably for the first like 12 years of my career, I would work on people's swelling, but I was more there just to kind of push them, like, okay, you got to push, Bev, like you got to push through the pain. And I'm your cheerleader. And
that's kind of why we don't really like you guys that much.
Yeah, exactly. I mean, it's all good. Yeah.
We want pain and torture anyway.
Yeah. It's funny because for most of our clients, our job is to make you feel better. And with a total knee, sometimes like, well, we're just here to push you. But what I've found, especially last couple of years, is if I just solely focus on people's swelling, then the motion comes by itself.
Yeah.
And yeah, you've still got to do your stretches, but you don't have to push nearly as hard. So, if you're working with a PT or, you're about to work with a PT, feel free to just kind of pipe up, I guess I would say, and say, hey, can you get that swelling out of my leg for me? And what it usually involves for me then is putting you laying on your back with your leg up in the air and grabbing my tub of massage cream and just like pulling the swelling down for you.
Yep.
And of course, making sure you know how to do your exercises. But to be quite honest, those exercises aren't rocket science.
No, they're not. No,
like,
they're not.
Bend your knee. Straighten your knee. You know what I mean? Like, so, I might spend, we have a 40-minute treatment session with our clients. So I might spend 10 minutes making sure you're doing the right stuff. But then I'll try to, especially early on, spend the other 30 minutes getting that swelling down for you, stretching the knee for you, stuff like that. And just so you all know, there's a huge range of what you can expect to experience in outpatient PT. And it can vary just inside the clinic too, depending on which therapist you're working with. So that was swelling. We're going to talk about that a little bit here on number 7 as well. The last kind of fill-in spot on number 6, though, was focus on stretching and quad muscle activation.
I've got a question that my orthopedist recommended, the constant motion machine. I can't remember what you call it, right after surgery.
Yeah.
And it seems to be a mixed bag on that. Some surgeons don't recommend it, but I thought it was very helpful. It just kept it moving, where you didn't feel like moving it, but it did it for you.
Yeah.
Several times a day.
Yeah, like you said, Sandy, it's a really mixed bag.
Yeah.
Some of the surgeons really like it, and a lot of surgeons don't like it at all.
What's your feeling? Any?
I think for some people it helps, especially if you have a hard time being mobile on your own. And for some people who don't have the hard time, it drives them crazy. So it probably has more to do with your personality than anything. And if you're okay with putting your leg in the machine for several hours a day, then I would definitely say use it. It's not going to do you any harm. But then some people really struggle with, the surgeon will say be in that machine for 6 hours a day, and they really struggle with that. So yeah, they do that with hip surgeries now too, a lot with labral surgeries. And
do they?
One of our PTs just had labral surgery, and she's a real go-getter. And she did it because the surgeon was adamant, and he's like the best hip surgeon in town, so you don't want to mess with him. But yeah, so with total knees, I think it is a mixed bag in the research too, whether it does any good or not. But for some people, I think it definitely helps.
Okay.
Yeah.
I think the icing does help. I rented one of those ice machines locally, and I think the person who was asking about help, it helped a lot to have my husband get me hooked up in bed at night on that ice machine. I mean, sometimes you can do it yourself. I thought during the day on the couch or something, but at night in bed trying to get coordinated, it was really helpful to have somebody else coordinate that or get me going.
Mhm.
Yeah,
And use the ice.
you said you rented that in Spokane, so it is available?
Yes.
Okay,
Down at, I think it was the Bellevue.
that's who I was gonna ask about. It was Bellevue.
Yeah, I think it was down there. And then you end up keeping part of it, anyway, it's
Okay, thank you.
reasonable, cheaper than buying one. Or if somebody has one, they could loan it to you too sometimes.
Okay, thank you.
I would imagine you could probably go on like Facebook Marketplace and probably buy one too. Because I think there are people that end up with them, they end up keeping them and then not needing them.
Right.
But renting is a good option as well. Yeah. Okay, so number 7, then I do want to talk more about some of the questions you all have had about longstanding pain, stiffness, and swelling. So these are just some more tips that I want to throw in. Because again, let's say 10% of people are going to have longstanding issues with pain, stiffness, swelling, redness, heat, things like that. So my first tip for people, if possible, is to decrease your swelling and edema before surgery, if you can. Now, if you're after surgery, obviously this doesn't mean a whole lot to you. But Anne, this one should hit home for you. Basically, when it comes to your knee being swollen after surgery, it's not just your knee that's swollen. It's typically your calf, it's typically your thigh. And if you have issues with swelling before surgery, and it could be related to something specific, like Anne mentioned earlier with edema related to a kidney disorder, or it could be just like you carry a lot of edema in that leg, or you have swelling that's backing up like into your abdomen. Anything that you can clear before surgery is going to make it so much easier for your body to clear that extra fluid after surgery. So for example, a lot of people just have swelling in their legs, and it could be an abdominal issue. It could be a inguinal groin issue. It could just be, kind of a general cardiac issue or circulatory issue. Whatever it is, if you can clear the streets before you're about to flood them with more stuff, it's going to make your life easier. And specifically for you, we're going to get to tip number 3, which is going to be specific for you. So just bear with me just for another minute or two. So that's a big one for people. Get in before surgery, clear the swelling. Again, you're about to flood your venous system and your lymphatic system with a ton of fluid. And if it's already working properly, again, the streets, the highways are flowing, everything's moving, it's going to clear itself much faster. So that's number 1. Number 2 is if you already passed what I would consider like your initial rehab phase, let's say you're past like the first 3 months, 6 months, 9 months, what I would encourage you to focus on now is aggressive treatment. So again, maybe you didn't want to get too aggressive early on, and that's fine because there's lots of pain and swelling. But later on, again, you're fighting for every degree of range of motion, and you're fighting to loosen that knee up, and it's getting harder and harder to do. So that's the point where I really encourage aggressive stretching and aggressive like scar tissue treatments.
Oh yeah, that was a question. Can you talk about the scar tissue?
Absolutely, yeah.
Okay.
So scar tissue. So in Bev's case, she kind of mentioned the scar tissue around her incision because it's a double incision now, right, Bev?
Yep.
They've reopened it, yeah.
Yep.
So that scar tissue underneath your incision can limit your mobility and cause pain. And then for other people, they're getting scar tissue, they're getting more pain along like the inside of the knee is really common. Outside of the knee is somewhat common, not as common as inside, or even like the end of your quad above your kneecap.
Yep.
Any scar tissue around there that you can just break up and loosen up is going to make your knee easier to bend. Scar tissue and adhesions can also keep the swelling there too. So when you're breaking that stuff up, it's going to release some of that swelling in the fluid. So there's different ways to break up scar tissue, and there's different ways to stretch aggressively. When we get clients that are 6 months out, a year out, 2 years out, that's what we're focusing on though, is really aggressive, like hands-on treatment techniques. So
Okay.
I prefer to use like scraping tools myself. If there's PTs have different types of scraping tools. There's Graston tools, there's this, there's that. But either way, I like to use a scraping tool so I can just get in there and like really dig into the scar tissue. Some therapists will use their hands, although it's a lot of work for your hands to dig into scar tissue. There's other things too, like cupping nowadays. You can use cupping, like with a friction massage while you're cupping. So there's some good techniques. And I would say in general, if you're at that point, or like Greg, you're in California, you're probably gonna have to call around and ask if anyone does that.
Okay.
Otherwise, you might just get kind of a repeat of what you had before, where someone's just basically telling you to stretch.
Right.
My physical therapist did spend time on the scar tissue and did use a bone or whatever,
Yeah.
you call that, a scraper,
Yeah.
and put lotion down. So I do think that's really helpful. And even now, just sitting around watching TV and stuff, if you can, with your fingers, really push in and dig around your knee and wherever you're hurting, it really is, I think, good to keep doing that.
Yeah. So you had a good PT, it sounds like, Donna. I mean, I'm not trying to rag on my fellow PTs, but I think a lot of us just get comfortable. We really like total knee clients because to some extent, you guys are easy clients because we know what to do. But then unfortunately end up doing the same thing with everybody. And that doesn't do you much good. It doesn't do you much good. Maybe it does me good because I, take like a mental break, I guess. But you really do want a PT who's willing to do something with their hands and, reduce the swelling like we talked about earlier with their hands, break up the scar tissue with their hands. Nothing makes me cringe more than like having someone come to PT and just do the same exercises they've been doing at home. Like, I just think it's a poor representation of our profession. Yeah.
Well,
and sometimes you get away with it, but yeah.
Yeah, it is because it doesn't take very many times to realize that I can do that at home. And I live in a community where there's 14 heated pools. And as soon as I could get in the water, walking in the water was fabulous and it doesn't hurt.
Yeah.
So I just started doing that. And then stretching in the water is easier too.
Absolutely.
And so, yeah, I mean, yeah, I need to find a PT that will actually do some different things.
Yes, absolutely. Yeah. And some people do just need the routine and the rhythm of coming in for PT twice a week. And that's great. But again, I think as PTs, we have to challenge ourselves to add as much value as we can. And especially for people that are more proactive. They said, look, Luke, I did this. I've done it. I actually did this already today. Well, then I'm going to make you do it again because you showed up in my clinic. It's like, I wouldn't want to pay for that or devote an hour and a half of my day to that if I was you. And then Bev, you made a really good point. And Ann, this is a good one for you too. The pool is great for swelling and edema. Walking in the pool, exercising in the pool, standing in the pool. Because you have that pressure gradient of the water. So, the deeper you go in water, the more pressure there is. So there's a natural pressure gradient pushing fluid back up towards your core.
Oh, cool.
Back up towards the top. Yeah. So back before COVID, we had an aquatic therapy program for years. And then we were doing it at a retirement center in town. So we haven't been able to get back in there since COVID. But a lot of our total knee clients would end up going to the pool even just one day a week and do the other 2 days in the clinic. And that was great for them.
Yep.
Well, I went to warm water. It didn't really help that much. I was doing a lot of exercise. And as far as the scraping, I'm not sure what that is exactly. My physical therapist doesn't do it. Should I ask her about it? What is scraping exactly?
Yeah. And you know what? Let me type into the chat here real quick. The tools that I like to use, they're called gua sha tools.
What is that? How do you
Spell
spell it?
that.
I just typed it into the chat there.
Oh,
It's,
I lost it. I don't
no
know where the chat
problem.
is.
Yeah, it's GUA space SHA. Now, like I said, there's 1,000,001 scraping tools online. PTs, we got metal ones, we got rock ones, we got bison horn ones, whatever.
Well, how do I know if it's appropriate for me? How do you know if you need it?
Ask your PT, I would say, but more than likely, if you're feeling kind of stuck, Carol, which is what I'm kind of picking up, more than likely you need to change something up in friction massage. Friction massage shouldn't hurt, by the way. Now there are therapists who like to hurt people, but not most of us. So you can do a friction massage where you're getting into that kind of that nitty gritty tissue and scraping it. And it shouldn't like hurt. It should feel like you're doing something, but it shouldn't like make you feel worse. So I would ask your therapist, Carol, check out those gua sha tools if you just want to see what I'm talking about. You can probably pop those into Amazon right now and find, you get like 5 tools in one for like $25.
Really?
But you have to know how to use it. I mean, I wouldn't know how to use it.
I hate to say it, but you can YouTube it.
Yeah.
I don't have a ton of gua sha videos yet on YouTube, but maybe
So
I'll
it's
make a
something
video.
I should do for
There you go.
myself. I should do it to myself.
I would recommend having a therapist do it for you, for
Well,
sure.
I guess if she never mentioned it, she doesn't do it. I mean, she never mentioned this. So I don't think that's in her repertoire.
Well, you're at the point where I would probably have an honest conversation and say, we've got to change this up, because you said you're 9 months out, right, Carol?
Yeah, and what concerned me too is you said people usually walk after 2 weeks. I can't walk. I mean, I'm really limping badly. I have
Yeah.
pain. And I was not limping before the surgery.
Yeah. So and is your knee pretty stiff too, Carol?
Very stiff. I do
Yeah.
stretching exercises.
So I would say that you're at the point now where something needs to change. And if the PT you're working with can change, can again change up the treatment strategy, start working on swelling and scar tissue and aggressive type manual techniques. If your PT can do that, then great. And if not, you might just start kind of calling around a little bit. Ask your friends,
Yeah.
read some
great.
reviews online, call a few clinics and just ask them and tell them what you're dealing with. If I had to guess, the current PT you're working with is not going to be the one that gets you where you want to go. He, she, they've had 9 months and you're not where you need to
No,
be.
I've only seen her a few months. I wasn't,
Okay.
I was at assisted living for a few months because I couldn't manage
Oh.
for myself. I've only
Gotcha.
seen her for a few months.
Okay. Well, yeah, talk to her about some of the stuff we talked about today and see if she thinks it's a good idea. Maybe she is the one, that helps you with it. But you might just have to be a little bit more of your own advocate, saying, well, can we do some of these techniques that are a little more aggressive or that we haven't tried yet? And if she seems open-minded, maybe you can work together.
I don't think she knows them, or she would have tried them. She would have tried them. She hasn't.
Are you in
she doesn't-
Spokane?
I'm in New York City.
Oh,
Oh,
Carol, okay.
Should be lots of options at the very least, right?
No, not everybody. I have a complicated thing, and not everybody knows what to do.
Okay. Yeah, again, she could know how to do that stuff and just hasn't thought of doing it. I mean, I have therapists that work for me that aren't always using all of the tools at their discretion, Sometimes they just need a little bit of an awakening or, a reboot or something.
What does the squash do? It loosens your knee more, or what? What is it, the purpose of
That's
it?
just the tool. So it's the scraping tool that I use. So it's just the tool
And what is the purpose of it? To loosen your knee?
to break up scar tissue. Yeah.
To break up scar tissue?
Yep. Loosen the knee, and then it improves swelling typically as well.
Yeah, I don't think she's ever done it. I don't think she has ever done it.
Yeah.
Has she ever worked on your incision?
No. How do you work on an incision?
Well, that's where sometimes they use that device to go up and down on your incision.
No.
Because that's where you also have scar tissue. And if it's too tight, then it does limit your knee movement. That's how I understood it. So I know they worked on my scar tissue separate from exercise and such.
Yeah.
No.
but
Yeah.
I
I
don't
think
know where to go. I think I have a good therapist, but I don't think she's as sophisticated as you're describing.
Yeah. And these are pretty well-known techniques. It's just a matter of applying them. So
Well, I don't want to be the first person she does it on.
That's true. That's true. Well, again, I would do some more research if I were you. Poke around the internet, make a few phone calls. There are people who advertise that they're certified in these techniques as well. So find one of them, find a clinic that specializes in manual therapy, what we'll call it, hands-on therapy. Because at this point, generic exercise-based therapy isn't going to probably get you very far at all.
Why do you say that? It's too far in?
Yep.
When you say generic, the stretching, I mean, I'm going crazy. I do this all day. You know, I'm always constantly, I mean, as much as I can, stretching and, you know, the spike and whatever I can do.
Yeah, well, I think a good way to summarize it,
Yeah.
I think, is if you go to therapy and you're doing the same thing in therapy at this point that you're doing at home, then
Yeah.
there's no reason for you to go.
Yeah.
So the therapist should be adding a different level of value that you can't add on your own.
Mhm.
Like the scraping you're saying.
Any type, there's tons of different types of hands-on techniques. Scraping is just one of, I think, the better ones. But if your therapist isn't doing something different than what you're doing at home, especially 9 months out, then I think you need to find someone who will do something that can, again, take you to a different level.
Luke, have you done a video on even hand massaging your scars?
I haven't. No, I'm writing notes as we go here, though, because I need to make some more videos. So,
Because your videos are free, right?
oh yeah,
And so if people don't know that, I mean, they're
I know.
tremendous. They're very, very good. And I use them pre-surgery, just off of YouTube.
Yeah.
And so I think if people don't know about that, but that would be something, because just doing a good hand massage on your scar tissue is also helpful, isn't it?
Oh yeah,
You know,
absolutely. Yeah. Yep. Okay.
So what would I do? I'd call up different places and say, do you do scraping? Do you do, what would I ask them even? How would I know? How would I know what to
Yeah.
ask?
I would say you would ask them if they do any type of friction massage. So friction massage would be a good keyword to throw out there.
Mhm.
I'm going to type this into the chat for you too. Graston.
What? I don't know where the chat is. I don't know.
Oh,
where to get
sorry.
the chat.
So write this down. Write down Graston, Graston.
Mhm. Yeah.
And then write down IASTM. If they don't know those keywords, then you're in the wrong spot. Graston is a specific type. It's a specific brand, basically, training of friction type massage with very specific tools. And then IASTM is the generic, like, umbrella term. It stands for instrument assisted soft tissue mobilization.
Nice.
Instrument assisted what?
Soft
Soft
tissue
Yeah.
mobilization.
What was
So
it?
when I
And you-
document my use of gua sha tools, that's what I'm documenting. I just document it as ISTM.
Your use of gua sha tools.
Yeah, I use gua
Yeah,
sha tools, but again, there's a million tools you could buy online.
Yeah, but I don't think I could do it myself. I don't know how to do it. You
You'd
said
be
watch the
surprised, Carol.
YouTube.
Watch some
Watch-
YouTube videos.
Yeah.
Some good stuff out there, some bad stuff too, but you know.
You don't know
it's
any
all those.
places in New York or anybody in New York, do you?
Are you like
Anybody?
actually in New York City?
Yeah,
Okay, I'll poke around for you too.
please, because I
Yeah.
think she's good, but we're just doing the stretches and that's over and over the same thing. Stretches
Yeah.
and it's not working.
I'll post it in one of my therapy groups later today and see who I know
Thank
who's over
you.
there. Yeah,
And you
you're
have
welcome.
my contact information there.
Yeah,
Thank you,
you
because
do.
I'm really upset, I'll tell you.
Yeah,
It's taken over my whole life.
yeah, I
And I'm
don't
not
blame
getting
you.
anywhere.
Yeah, I don't blame you there. Yep. Okay, let me get through that third tip and then we'll kind of get through the
Thank you.
rest here, and yeah, people can hang out longer if they want. So tip number 3 then, and this this one's just for you. Work with a lymphedema trained therapist. So
Okay.
lymphedema is that blank spot there.
Unfortunately, I'm familiar with that term. I'm a cancer survivor that's lost some lymph nodes. So I'm familiar with lymphedema.
Yeah. Have you ever worked with a lymphedema therapist?
No, but they did very much say if we're traveling to put the sleeve on that particular arm and all of that. And I had only one bout with lymphedema, which is when I got stung by a bee on that side.
Oh,
And I
yeah.
went back into the clinic.
How do you
and-
spell that? How do you spell that? A what? How do you spell lymphedema?
LYM
Yeah.
PHEDEMA.
Thank you.
Yeah, you're welcome. Lymphedema. Sorry, Ann, what were you saying there?
I would say that the only thing I was at Cancer Care Northwest when I had to go in and get a 2 days worth of drip for the bee. And then they worked on my arm and massaged it like you were talking about. And then
Yeah,
we watched it, measured it, and that seemed to take care of it. Plus they did a 2-day drip, which I guess encouraged my lymph system to get rid of things. Because
good.
I'm missing some lymph nodes on one side.
Yeah. And again, if you have lymphedema in your legs or just swelling,
Yeah,
see if you can find a lymphedema therapist. And I put that in the chat too. Look for a CLT. Look
okay,
for someone with CLT after their name.
thank you.
Yeah, and that's just a
I hadn't
certified.
thought about that, but it makes perfect sense for what I'm going through right now with
Yeah,
the post kidney stone dealing.
yeah. And so again, a CLT is a certified lymphedema therapist, meaning they went through a ton of training. Most of us PTs don't really dabble in lymphedema. It's very complex,
Mhm.
but you do have therapists that do. So, and I would say that's really good for pre-op and it's really good for post-op. Because again, post-op, if you have a ton of swelling, like, because again, some people just swell up horribly. The faster you can drain the swelling through your lymphatic system and your venous system, the faster you're going to be able to tolerate your stretches. The pain's going to go away faster. The motion is going to improve faster. So over the last couple of years, since we have a couple lymphedema certified therapists, we really try to get them into the rehab fold with our total knee clients because they just do better.
Perfect. I have a cancer doctor appointment coming up in 2 weeks, and I will ask her if she knows where the CLTs are. She
Yeah.
knows where they-
Yeah. Are
Is
you
that
in our
the-
area, Ann, or are you somewhere else?
I'm here.
Okay. Like I said, we've got 2 of them. So
Oh, okay. Well, I'm gonna do my prehab with you guys.
cool. Sounds great.
Thank you.
Yeah.
So that lymphedema is for swelling.
Yes. And usually, Carol, if you were to come into my clinic today and you're 9 months post-op and you had any amount of swelling with your knee stiffness and tightness, I would just push you over to the lymphedema therapist like automatically. Because they're also orthopedic, they can handle knees and they can handle friction massage and they can do everything else the rest of us can do. They just have that additional certification on top. So I'm not saying that the swelling is your ultimate problem, Carol, but if you do have swelling along with stiffness and pain, I would definitely try to get someone who can help you with the swelling as well.
I don't know if that's my main problem at this point,
It might not be. You might just have a really tight knee.
Yeah.
Yeah. Okay, so let me go through my last kind of topic here, and then I'll open it up again for questions. If anyone wants to stay longer, I'm happy to hang around. So what's next? If you're having surgery in the next 2 to 3 months, you are more than welcome to claim a free pre-op consultation with one of our PTs. So it's a 30-minute consultation, and kind of like we talked about with prehab before. Basically, what we do is we go in, we look over your knee, give you kind of our assessment, and then we give you specific instructions to work on before surgery. So we'll tell you, do these 2 or 3 stretches, do these exercises. Obviously, if you need any treatment and you actually want to work with a PT, you can do that too. But if you just want, again, a 30-minute consult, just so you know you're on the right track and doing what you need to be doing, that's completely free. So you can call the office anytime and just say, hey, I'm having total knee surgery in 2 or 3 months. I want to just get in for a free assessment, and they know exactly what to do from there. So that's always an option. I don't think I put my phone number on there, but that would have been smart. I'll post it in the chat, but our phone number is 892-5442. Oops.
Where are you located?
We are in the Valley.
Okay.
And we're on Mullen Road, just south of Broadway.
Yep.
Do you know that area, Bev?
I do. I live in Kettle Falls in the spring and summer and fall.
Oh, cool.
Yeah. But I had my surgery done in Arizona, in Tucson.
Oh, good deal.
Much easier place to recover.
Oh, I bet. Yeah.
You can actually get outside and walk.
Yeah.
Yeah. So anyway,
Absolutely.
but I'm up there during the during the years. So yeah, I know where you are.
Cool. Yeah, yeah.
Yep. Thank you
Really
very
good
much for
fun.
this seminar.
Yeah, you're welcome. So next bullet point there, if you're hoping to avoid total knee surgery, and you want to see if there's something we can do to help you prolong the knee before surgery, you're welcome to do a free consultation for that too. And just kind of side note, a lot of our clients, whether they're coming in for total knees or longstanding back pain and sciatica or shoulder pain, a lot of them will start with a free consultation this way. So it's specific to our clinic, but we do it all the time. And it's just to help people get a better understanding of what's going on and get an impression of if we think we can help you before we start jumping through hoops with, a referral or an insurance company or a copay or anything like that. So this is something that we're very well versed in, just so you guys all know. So whether you're in that first category, the second one, or the third one, kind of like Carol, where you're still dealing with ongoing knee stiffness, pain, swelling, any of those situations, we're happy to offer you a free consultation just so you can learn more before you decide if you want to do anything with us.
Very nice.
Yeah. Okay. That's my spiel.
Much appreciated. Thank you.
You're welcome. Yeah.
Thank you.
Good service.
Yeah.
It is.
Maybe-
I had a question about the bow-legged.
Yeah.
Okay, I understood when you have a knee going off, you either go in or you go bow-legged, usually on one.
Yeah.
And so I think somebody else had that. I'm wondering, so they told me I had my surgery on my left leg, but my right leg was then getting bow-legged. So now I'm wondering, since I've had that surgery, does that leg, the bowed one, stay kind of at the place it was, or can it continue to get worse? Does that make sense? Does it?
Yeah. So will it continue to bow, you mean?
Yeah, not that it's gonna get better, but is it gonna get worse?
It can get worse. Yeah, it can. The other thing that you might consider, Donna, if you're looking to really kind of avoid surgery or at least prolong it, is they do make braces specific for your situation. They call them unloader braces.
Mhm.
And so basically, if your knee is bowing, let's say that direction, the brace will basically try to push your knee back into more neutral alignment.
Okay,
So that can help you kind of delay the process too. But at your point, it could be bow-legged to the point where it's just done, or it could progress. You really don't know until time goes by.
okay. And do you think that just the knee compression sock is helpful rather than the whole full length one? Or do you think a full length one is better?
It kind of depends how much swelling you have. If you feel like getting it just above your knee is enough to kind of clear the swelling in the lower leg, it's probably good. But if you feel like then you just have a bunch of swelling in your thigh, then you might consider a full length one.
Okay, I think I wear them because it keeps them from hurting as soon.
Yeah.
And it's warm, so if you're out walking when it's cold, they actually keep your knees warm.
Yeah.
You gotta.
Yeah.
My doctor did tell me once to warm up, like before I got to garden and bend and stuff, to take time to warm your knees up and massage your legs some.
Yeah. Yeah. And with how active you are, you're probably okay with just the knee length one. But if you ever felt like it, the swelling was still just sticking around, you could consider a higher one.
I've got a question about swelling. Before I had the total knee replacement, I had a lot of swelling in the back of the knee. I think they call it a Baker's cyst. And that seemed to go away after the knee, but it seems like maybe it's coming back. I can actually feel swelling back behind that knee.
Yeah. Yeah, it can come back for sure. And it's just that spot that if you have a little extra swelling, it's just where it's going to go.
Oh,
So it is kind of a good barometer for if there's extra swelling just in that general region.
okay.
Yeah. So you could treat that if you wanted to, or you could try some compression
Yeah,
and just see if it goes away.
okay.
How did they treat it? Because I think I had that too. You mean they would surgically remove it, or they'd go in with a needle and empty it or something?
Sometimes they will do that, like they'll drain it, but usually they would just send you to therapy to PT and have them try to just massage it out for you.
It comes back, I think, if you drain it or.
Oh.
Yeah, a lot of things do, unfortunately. Yeah. Any other questions?
I think so.
Cool.
Thank you very much.
Thank
Yeah,
you.
you're welcome. Thanks for joining me.
Thank you
Uh,
very
Yeah, I
much.
actually do, Dr. Gordon.
Yeah, go ahead, Greg.
Okay, so kind of for my situation, like I said, I mean, I still feel like I have really good range of motion with my knee. I'm just kind of the point now where when I'm active, I end up with a lot of pain and not really tightness, I guess, more than stiffness, because it's not really stiff. And I'm kind of in this cycle where it's like, okay, I get on it and I do stuff, and then, then I'm sore and I'm laid up for a week or several days, and I kind of back off it, and then I'm a little better, and I go, does that make sense? And I go again, and then I'm sore. That's kind of where I am right now with it. Is there something you would recommend for my particular situation right now?
I would probably look closer if there is some scar tissue that's causing that pain and just try to figure out why. Why are
Right.
you getting sore? I mean, certainly you could maybe be a little more proactive with making sure like you ice and elevate after you work out.
Always. Daily I'm icing. Yes. Still.
Yeah, yeah, it's tough because you've got full motion, that sounds like you said. So
Right.
I guess I would probably just try to look into if there are any areas that seem to be kind of slowing you down or that have a little bit of scar tissue.
Right. And like I said, this has been a 2.5 year battle for me now, but I am going to be in the Spokane area in March.
Yeah.
Could I possibly call your office and do one of the free consults? Would that be appropriate for me or not?
Absolutely. Yeah.
Okay. And I do have, and I don't know about, like I said, we'll only be there for a while, but okay, if I'm still battling at that time, I will certainly do that when I'm up in March. So
Absolutely.
I appreciate the time. Thank you very much.
Yeah.
Have
you're
you
welcome.
tried, it sounds like you're I don't know how long you do your exercise, but I know when I've done a really extensive hike or something longer, I
Mhm.
certainly feel it much more. So I wonder if you broke your exercise up.
Right down. Yeah. And that's kind of where I am now. I mean, I try to walk for 20 or 30 minutes a day, and then, maybe get on my bike for 20 or 30 minutes of my exercises. And it just, whatever I do, I seem to end up, with a lot of tightness and a lot of soreness afterwards.
Right. And I also use CBD oil, and I don't know.
I have a huge jar of it.
Okay.
And I've used the Voltaren, as well, a lot
What's
of
that?
a lot of arnica,
What are those? What are those? What's this whole you're talking about? CBD? Well, what is it?
CBD is just a cream that's cannabis based, but it doesn't have the THC in it.
You rub this stuff in your
You
leg?
rub it. Yeah, exactly. It's a topical.
Does it help?
Nope.
Somewhat. It can.
I can
Dr.
notice that
Gordon,
I have
do you recommend these things? What do you think of these? What do you recommend of these things?
I like all of them. Yeah.
Well, I don't know what they're Voltaren. How do you spell them? CBD oil?
Voltaren is a prescription one.
Oh, it's actually over the counter now.
Oh, is it now?
Well,
How do
in
you-
California, it certainly is. I
How do
believe
you
Yeah.
spell it? How do you
think
spell
you're
it?
right.
POLTAREN.
TAREN. And what was the other one?
Now,
DM.
CBD you can get anywhere from Washington.
And the other one, what was the last one?
Arnica, ARNICA, I believe is how it's spelled.
Would you recommend that for me, Dr. Gordon? You think that would be helpful for my condition?
They're all good. Yeah, I would
Yeah.
probably I'd probably start with CBD personally,
Uh-huh.
but any of them
A
are
little
good options.
expensive. CBD cream's a little expensive, just so you know.
Yeah.
Well, I'll tell you, when it comes to your health, you're
Right,
not gonna
absolutely.
cut corners.
Okay.
Yeah, you can take CBD orally too,
Right.
and that has some good effects. Yeah.
Wow, I never heard of any of these things.
Yeah,
Great Northwest.
Yeah,
Right.
right.
New York's got it
Maybe,
too. I'm
maybe
sure.
I need what? Maybe I better move.
No,
Right.
I'm sure New York has it too.
Yeah.
All right.
Yeah.
I'm going to sign out. Thank you very much, Dr. Gordon. Good
You're
luck to all you
welcome.
folks.
Thank
Thank
you.
you.
Thank you. And
Thank
Dr.
you.
Gordon, I'd appreciate if you could, if you get any leads from me, because I don't know where to go. I really don't.
Yeah.
I've tried.
I'll go
Thank
post something in that therapy group right now and I'll see what I get for you.
Thank
And
you.
I'll email you. I've got your email.
Thank you very much.
Yeah, you're
I
welcome.
learned a lot. I thought this was very helpful. I never
Good.
heard of these. I never even heard of these things.
Yeah, good. I'm glad it helped.
Thank you.
Thanks.
Thank you, and thank to all the contributors who've had knee surgery, telling me things I need to know.
Absolutely. Yeah, thank you
Yeah.
all. It's a good meeting.
Yeah.
Good health
Thank
to the
you.
rest as you go through it.
Yeah. All right, you guys have a great day.
You too.
Thanks.
Goodbye.